My name is Jing. I'm a radiation oncologist specializing in the treatment of CNS malignancies with a particular interest in brain metastasis. You will see that I use brain mets as an example in my presentation, but LITT can definitely be used beyond brain metastasis. I will start by giving you a very quick and focused introduction so you will understand why, as a radiation oncologist, I'm so appreciative of having LITT as an option in our toolbox. And then Dr. Prabhu will lead the case presentation. So these are some of the Montaris disclosure. That's the outline. So as you all know, stereotactic radiosurgery is a technique that allows for delivery of very focused and high-dose radiation to the tumor and to the tumor only. It therefore has the advantage of sparing normal brain and providing excellent local control to the tumors. And also because it's one treatment only and the radiation is so focal, there is really no need to hold systemic therapy for a prolonged period of time. And this is particularly critical for this patient population, as many of those patients have progressive extracranial mets. Because of these advantages, SIS has been used with increasing frequency in the treatment of brain metastasis, as well as other CNS malignancies and even some benign condition. So as physicians, we want to establish or adapt our practice based on good clinical evidence. So the question is, do we have good evidence to support increasing use of SIS? And so the answer is yes, at least for brain metastasis. There are 3 lines of evidence to support increasing use of SIS based on multiple phase 3 randomized trials that published in recent years or to be published. So the first line of evidence came from 2 phase 3 randomized trials in patients with 1 to 3 brain metastases. The first trial was an MD Anderson phase 3 randomized trial that was closed earlier because of interim analysis showing benefit of omitting whole brain radiation. So this trial basically showed that SIS alone helps to preserve patients' cognitive function without compromising survival outcome. And these results are subsequently confirmed in a larger cooperative group study published a few years back. And again, this alliance trial showed that in patients with 1 to 3 brain metastases, patients who received SIS alone had better cognitive function. So how about for patients with 4 or more brain metastases? We have an MD Anderson phase 3 randomized trial for this particular patient population. The trial was closed to accrual later last year, and the manuscript is being written. What I'm showing you here is unpublished preliminary results. Please do not share with anybody outside this presentation. So this is basically a phase 3 randomized trial for patients with 4 to 15 brain metastases, and they get randomized to whole brain versus SIS, and the primary endpoint is Hopkins Verbal Learning Test, which is a memory test. So our preliminary results showed statistically significant difference in patients' cognitive function in favor of SIS. And the overall survival is not different between the 2 arms. So once published, peer-reviewed and published, this will provide evidence for the use of SIS in patients with 4 or more brain metastases. So the third line of evidence came from 2 phase 3 randomized trials in patients with resected brain metastases. So the first trial was an MD Anderson trial where the resection cavity was randomized to SIS or observation, and the primary endpoint was local control. So this trial basically showed that SIS helps to reduce local recurrence without adding additional side effects. And then the second trial was the NCCTG trial, where the surgical cavity was randomized to SIS versus whole brain radiation. This trial is also a positive trial showing that the SRS helps to preserve patients' cognitive function. So taken together, all these randomized trials established SRS as a standard of care in patients with 1 to 3 METs or 4 or more METs and those with resected cavity. So what is associated with increasing use of SRS is increasing risk of radiation necrosis that as radiation oncologists we have to deal with. And the increased risk of radiation necrosis is further increased by the use of immunotherapy. As you all know, immunotherapy has been approved in multiple types of cancer in recent years. And there are good rationales to combine radiation and immunotherapy. For example, radiation has been shown to promote antigen release, tumor antigen release, and other aspects of T-cell mediated immune response. It basically turns tumor into in vivo vaccine. On the other hand, immunotherapy can enhance radiation-induced abscopal effect, which is exceptionally uncommon by itself, therefore turning radiation from a local therapy to a systemic therapy. So specifically for brain metastasis, immunotherapy has been shown to have some CNS activity, even though we don't know exactly how it works in the brain. So what's associated with combining radiation, SRS, and immunotherapy is increased risk of radiation necrosis. What I'm showing you here is one example in literature on the frequency of radiation necrosis in patients receiving SRS for brain metastasis in the setting of immunotherapy. So typically, we quote 5 to 10% risk of radiation necrosis for SRS alone. When combined with immunotherapy, the reported frequency of radiation necrosis is in the range of 20 to 30% in the literature. So this definitely calls for better management of radiation necrosis. This is also why, as a radiation oncologist, I'm very appreciative that we have LITT as an option in the management of radiation necrosis. So here is a general algorithm on how we manage patients with suspected brain metastasis. So we typically observe patients if they are asymptomatic, and we treat them with steroids if they become symptomatic, or if they have significant amount of edema on imaging, causing things like midline shift. So if patients respond well to steroids, great. If they don't, or if they become steroid dependent for control of the symptoms, or if the tumor continues to enlarge, we typically do two things. So first, we present these patients at our weekly multidisciplinary brain metastasis conference, attended by neurosurgeons, radiation oncologists, neuroradiologists, and sometimes medical oncologists for imaging review and for discussion. Around the same time, we order advanced brain imaging, including things like perfusion scans and spectroscopy. We started with steroids, either the patient do not respond or they become refractory, or if the lesion continues to enlarge. So we usually discuss the patient in a multidisciplinary fashion. We also order perfusion scan and MR spectroscopy to help us differentiate between radiation necrosis or tumor recurrence. We sometimes do a delayed PET, which is basically acquisition of a positron emission 5 hours after injection of the radioactive FDG. So at the end of all those imaging studies and discussions, if we believe we're dealing with radiation necrosis, the patient will be considered for Avastin or LITT. If we think we're dealing with a recurrent tumor, the patient will be considered for LITT or resection. So I was asked to share a case with you where the patient was successfully managed with steroids without need for further therapy. So this first case is a 35-year-old patient with metastatic mucosal melanoma. treated with stereotactic radiosurgery for actually multiple brain metastases. And one of the lesions is located in the brainstem. So as you can see in June 2019, on the leftmost image, I treated this not so small lesion in the brainstem to 18 gray, 1 fraction. A month later, it appears that she was responding, was on track, was going in the right direction as the tumor was a little bit smaller. And then 3 months later, we have this enlargement of the enhancing area with more edema. So at that time, she was not hugely symptomatic, so we treated her with steroids. So I became very concerned in December. As you can see, the area has become a lot larger and there's more edema. She was also more symptomatic. So at that time, she also developed other metastases. And I was debating whether I should do whole brain radiation or continue observation. So decided to do whole brain radiation. However, she lost her insurance coverage at the end of the year. So she was lost to follow up for 3 months. I was very worried about her, but very pleasantly surprised in March when she returned. The brainstem tumor looked much better with reduced enhancement and reduced edema. And that lesion continued to improve on her July scan. So this is one example where a patient responded to steroids without the need for further therapy.
Okay. Good morning. I'm Dr. Prabhu. I'm neurosurgeon at MD Anderson. And that's a number of familiar faces. I'd like to thank the folks from Terrace for this together. So please chime in. You can stop the presentation because these are mainly case presentations from a series of my own. So I'll start off with this 67-year-old lady with metastatic breast carcinoma. And this is progression following SRS. So what you see here in this slide is a axial T1 image post-contrast on the left, showing a fairly large mass. It measured about 2.8 centimeters in the post-central gyrus. Patient presented with right arm symptoms and weakness. What we did here was give her the option of surgical resection versus laser interstitial thermal therapy. She chose to do LITT. And what you see on the right side of the screen is a dynamic contrast imaging scan, which is done after laser interstitial thermal therapy. We get these scans routinely on all patients intraoperatively, since all our cases are done in the intraoperative MR. What I'd like you to focus here on this particular slide is obviously you see this necrotic lesion in the middle. This is post-treatment. You see this very bright signal on the periphery. But more importantly, you see these pixelated spots in the margins, and we pay special attention to that. In fact, I think that might be the source of recurrence in some of our post-LITT patients, and we've been following these patients over time. So in this particular case, you can see there are 3 sets of scans from left to right. The immediate post-op scan was done in October of, which is approximately a month later, and you can see there's already an area of recurrence. And the reason it might be the case is you can see adjacent to the lesion a sulcus, and the sulcus clearly has blood vessels. It has CSF within it, and these are areas of heat sink. So this is a well-known challenge we all face with patients undergoing laser interstitial thermal therapy. And I just want to bring this to your attention in terms of being aware. You can see in 3 or 4 months that area of the mass has increased, while this cystic-looking mass has kind of gotten smaller in size. At this point, unfortunately, she had not too many options. We could go back and LITT this area, but we chose to give her the option of a resection, which she had in January of this year. Since then, she's continued to do well. The area where we resected looks a lot better on her most recent scans. Unfortunately, she's developed distant metastases. So I'll move on to the next case. If you guys have no questions, this is a 60-year-old female with metastatic breast carcinoma to the left cerebellum. As you can see, all the cases failed steroids. Again, scans from left to right show a contrast enhanced scan primarily in the left cerebellum. And you can see the DCE scan, which is in the middle, showing some uptake, which is the whole area, and a fairly significant amount of edema. And clearly the option here would be, as a surgeon, you think about resection, but it's clearly deep and adjacent to the lower brainstem, and hence we decided to pursue with laser interstitial thermal therapy. Again, this is a posterior fossa lesion. There's a lot of planning which goes into placement of the probe in terms of getting the trajectory right. So in this particular case, we chose to do laser interstitial thermal therapy. These are images from the intraoperative MR. You can see the post-treated LITT. You can see the probe towards the lesion centered well. And what we typically get post-treatment are 2 sets of images. I mentioned the DCE, which is on the right side, but also you get a T1 subtraction image, which is basically mirrors what we see on the DCE. So at this point, we felt comfortable that we had attained a good resection, a good treatment. And in most of our cases, we do get samples of tissue sent to the pathology lab. This is mainly single or maybe 2 samples. And in this case, it was all necrosis. There's no tumor present. So you can see this is 2 years after treatment. The patient still comes for follow-up. This is her last scan. This was last year. She's due for a scan anytime soon. And you can see the lesion is pretty much a shell of its previous self. And also the significant difference in her T2 signal with no edema.
Sujit, I have one quick question. So we know that when you have these cerebellar lesions, if you get doing a resection in the cerebellum, especially a piecemeal resection, there's a higher risk for leptomeningeal disease. When you do this LITT and do a couple of samples, what's your rate, or have you seen an increased rate of leptomeningeal spread?
That's a good question. I don't think we have, but I will tell you one thing about the placement of the probe, and I think we typically start treatment of the lesion from superficial to deep, because I've had one case where we've had CSF, or I should say tumor seeding along the probe tract, and hence we try to treat the lesion from superficial to deep. But no, I've not had any case of CSF seeding.
I have another question. So many times we'll follow these patients like in conjunction with our neurosurgeons and the multidisciplinary brain meds clinic, but many patients are not, since there's so many of these types of patients. Is there an algorithm you can provide for radiation oncologists in terms of just spatially, maybe certain no-go areas? You had alluded to a heat sink effect earlier. Is there a size or volume limitation, or like a location limitation, or even is there consideration for that sort of post-LITT edema and flare, which seems to be self-limited, but is there ever, does your decision-making for LITT candidacy ever hinge upon or is influenced by the consideration of that sort of transient spike in edema and its functional consequences?
Yes, again, I think we looked, and I've got some slides to follow. It's primarily the size of the lesion which matters, and in terms of the optimal size for LITT, we've treated lesions as big as 4 centimeters in diameter. Now the location, as you mentioned, matters because if they're adjacent to CSF pathways, clearly, as you can see, as you saw in the previous case, that there is a heat sink. The challenge there is real. It's not uniform, I should say, across with most cases. The other areas for heat sink would be, I'm pointing to the venous sinus here, and I've had more than one case, especially in the posterior fossa, where we've challenged with recurrences just adjacent to the venous sinus. We've had patients who present post-LITT with significant edema, especially if it's close to CSF outflow tracts, primarily the posterior fossa or adjacent to the third ventricle. That can be a challenge in terms of management. But one of the things I do when I see a larger lesion, anything more than 3 or 4 centimeters, I use the probe. They come in 2 different probes, 3.3 and a 2.2 probe. And the smaller probe clearly helps in offsetting the amount of what we call the treatment wattage to the tumor, and hence by providing less of the LITT current, we can offset the amount of edema. And I think that's something you can work with in terms of just using a different probe.
And one follow-up question: what about for lesions that would be traditionally a little more difficult to resect, let's say something in the basal ganglia? Is there a wider eligibility for patients to be LITT candidates if they have a lesion in that area?
Yeah, so we have a good case series of patients with LITT in the basal ganglia. And again, like I said, the size matters, and these are typically not resectable tumors, even among our neurosurgery colleagues here. You would agree that they carry a very high morbidity. So again, I tend to respect the size. If it's a large size tumor, 3 or 4 centimeters, we typically use the probe, which is smaller. But I've had probably one case where we had to place a ventriculostomy post-LITT, but you just have to keep that in mind. It's not that we do not do these cases, because surgically the options for surgery are really limited in these patients.
Yeah, perfect. So I have a question regarding your first case. When the lesion is very superficial, I have always challenged to see like a lot of artifacts, so I cannot really see the contrast enhancing in the MRI. So do you have any tricks to make it because the bulk makes a lot of artifact when the lesion is superficial.
Yeah, so a couple of things. When you place the bolt, typically when you place the bolt, you don't want to go all the way down past the inner table. I think we've had some challenges in the past. So while placing the bolt, just pay attention to the depth because it's very easy to go past the inner table, and I think that will throw artifact to the upper layers. That would be one thing. The other issue is primarily avoiding any type of air pockets, blood, and so on. They can also, be a source of pixel dropout.
So then if the lesion is superficial, you don't see it really like contraindication for LITT.
No.
Okay, thank you.
So Sujit, how about for lesions that's hemorrhagic? Is that a contraindication?
Yeah, so that's a good question because hemorrhagic lesions typically, are filled with blood. Blood, really appears very dark on scans. The pixel drop-off is pretty high. Interestingly, when we used to treat melanoma in the past, and we've had a number of patients. We haven't had patients recently. It seems that we always seem to have good coverage. It may be the tissue, the type of tissue we're dealing with, because at least in melanoma meds, though you have a hemorrhagic component, there always seems to be a tumor portion within that mass, which clearly has a different density. But purely blood, yes, I think there would be a challenge in treating those type of patients. All right, I'll move on with our next patient. She is a 60-year-old female with, again, metastatic breast carcinoma. Again, this is another case of, let's see here. No, that comes later. This is an interesting case. She presents with a left parasagittal meningioma, which was treated elsewhere. As you can see in a series of scans from left to right, she presented with an initial scan in 2015 with this lesion in the left parasagittal region adjacent to the corpus callosum. She then underwent observation. This was all at an outside institution. And at this point, there was an increase in size. She underwent SRS. This was an outside institution. Within 6 months, you can see this tumor had increased in size. Obviously, it continued to increase. She presented to us with this scan, and assuming she had no past history of any primary disease, and this was clearly progressing in size, a lot of edema. I don't have the scans to show you, but she was very symptomatic with primarily left parietal lobe symptoms. This is again a deep location. We chose a left parietal trajectory, and again, you're seeing two sets of images: a DCE scan on the left and a subtraction scan on the right. We got excellent coverage. I'll show you the scans post-op. Now, the pathology in this particular case was clearly a lot of necrotic tissue with foci of meningothelial proliferation, suspicious for meningioma. So this was the first time she actually had a biopsy of the lesion. What you're seeing here are sets of scans from 2017 through March of 2020, and you can see the significant regression in terms of the mass lesion itself, and all her edema has gotten significantly better. So this was a case which obviously forced our hand into doing LITT, clearly a good indication. Again, I think in this particular case, probe placement is critical in finding the appropriate trajectory. So I will go with our next patient. This is a 60-year-old male with metastatic renal cell carcinoma, failed SRS. And as you can see, this is very similar to the lesion you saw in the past with the breast carcinoma lesion in the left cerebellum. This was back in 2018. This is post-LITT, and this is his most recent scan. I just saw him not too long ago, and he's presently asymptomatic. He's got very stable renal disease, and overall doing very well. Again, to show you the effect of LITT on edema, these are his scans. Obviously, the edema pattern sometimes gets worse in the first couple of months to 3 months after LITT, but then we see a steady regression. And in this particular case, you can see that we achieved a very good result. So this is a interesting case of a patient with carcinoma. Who presented with this lesion, again, a superficial lesion. You can see it in the series of scans from left to right. He presented to me in March of 2018. And at this point, this was an untreated lesion. We chose to resect, which we did. You can see this is a scan a month after resection. And then he underwent focal radiation of the tumor bed. What we did notice within a few months after treatment was there was this soft tissue tumor, which was actually forming within the cavity itself. And we did get some advanced brain tumor imaging, which confirmed this to be possibly tumor. And he was getting more symptomatic at this point with significant right arm weakness and apraxia. So I spoke to him. The options would have been to go in and resect this. Clearly, he was very apprehensive. So we chose to do LITT in this particular case. Again, this is again a superficial lesion. Just paying attention to the placement of the probe and so on and so forth. And we got a good result. And you can see on his most recent scans, this is a lot of post-treatment artifact and so on, but really no edema per se. He's doing really well. This is probably one of the few cases I've had to do LITT in a post-resection situation. And again, as you can see on the pathology, there was no tumor present. There was a lot of treatment-related changes in the tissue. So I'll quickly run through some of the slides in terms of our own publications from MD Anderson. This was published in Neurosurgery a year or two ago. This is our series of patients with brain metastases, and we had a number of different types of tumors. Again, the breakdown, as you can see, predominantly with breast. We had a good mix of melanoma, which we don't see as often. And in the past, we've used the Visual A system, but more recently, I at least use only the Monteris system. And we broke this down into dural and non-dural based, primarily because to look at the differences in treatment and recurrences. We looked at obviously whether they had a complete ablation or not. And as you can see, based on tumor volume, patients with a higher tumor volume measured at more than 6 cc's, and 6 cc's basically is probably just under 2 centimeters. had obviously a progression which was seen sooner. Again, the patients who had an incomplete ablation also fared poorly. Dural-based lesions, again, are a source of heat sink, and they had recurrences sooner. When we think of lesions which are either necrosis versus recurrent tumor, patients with lesions which had recurrent tumor obviously had more early recurrences than if it was only necrosis. And what we did here was we also looked at the role of systemic chemotherapy, and I think that's one of the utilities of doing LITT, because as most of you are aware that it that affects or changes the blood-brain barrier permeability, and in this case, patients who received systemic chemotherapy before and after LITT, and this we resumed very quickly after treatment, did better than patients who did not receive systemic chemotherapy. So when we looked at our multivariate Cox regression for progression, 3 variables stood out. So patients with or without systemic therapy, dural-based tumors, and the indication meaning patients who had tumors did not do as well as patients who had treatment only for radiation necrosis. And again, the complication profile is not significant in these patients. A lot of patients leave the next day. And I think in terms of application which we put together for cancer letters more recently, this more in terms of our experience and philosophy, which was just published. And so this was I took this picture from the manuscript itself. As this is a panel of a single case treatment, I just want you to focus on this slide at the bottom here on the left, and you can see as we treat these lesions, we get these different lines. Obviously, these are thermal damage treatment lines, which are seen on our computer model, and the white, blue, and the yellow line represent different heat damage lines. And what we want to accomplish is the entire margin treated tumor should fall within the blue line. Anything outside the blue line has a potential for recurrence, and that is the yellow line. So this is what one would see during the patient had a good result. This was again a post-central gyrus metastasis. So I think Dr. Lee alluded to this flow diagram. This is again very simply put our algorithm in terms of how we look at post-radiation treatments and the challenges we face. Like Dr. Lee mentioned, we do get consecutive MR scans. These are done every couple of months or every 3 months, depending on whether patients come back for follow-up. And we have a multidisciplinary team, and these meetings are held on a regular basis. Neurosurgeons, neuroradiologists, obviously Dr. Lee's team, and we all review the scans together. A decision is made based on MR features, and then we get an additional imaging consisting of what I call ABTI, which is DCE, DSC, and MR spectroscopy. We have been using delayed PET, which I think has a lot of promise, and then the decision is made in terms of whether these patients will have interstitial thermal therapy. So I think that's my last slide, guys. So
yeah, thank you. Thank you, Sujit. I mean, it's a great presentation. I remember an awesome case that you and I worked on together there when I was a fellow at Anderson, where a young lady had the option to use LITT to defer open surgery and defer the open craniotomy, and also defer the use of chemotherapy during pregnancy. And she was actually in her second trimester of pregnancy, and there was the risk for the tumor to come back. And we opted for LITT, and she had a GBM. We opted for LITT in her case, and it held off the tumor long enough for her to get through the pregnancy and not just take the baby at viability, but indeed she was able to have a normal delivery, and then we were able to start chemotherapy afterwards. So that, an interesting case, yeah. But I wanted to ask, here, and you guys touched on a little bit, and Dr. Lee may have mentioned a few points. I think it's really important, and that's why I like to join these calls, to really talk about the fact that LITT and SRS, they open up the blood-brain barrier that otherwise may be just slightly compromised by the tumor itself. But opening up that blood-brain barrier allows for better, penetration of as a neuro-oncologist, systemic therapies and things of that nature, which also contributes a great deal to some of the downstream improvement that we see in these tumors. I wanted to see if, you would also add, like in the future, information about how soon we follow up with the systemic therapy. Like I said, Dr. Lee touched on it, but the potential to use, in this case, immuno-oncotherapies for these patients now that the blood-brain barrier is open. Other targeted type therapies may be more suitable in these patients after these types of therapies. And I just, I know for a fact, that I follow up very closely, and you guys have a great neuro-oncology team there at Anderson. So I know that they're also following these cases, and it may be, some component to how the patients do downstream.
That's a great point, and we do have an open protocol with neuro-oncology using CCNU post-LITT in recurrent glioblastomas. And I can tell you from the limited experience we've had with patients, I think there's clearly an advantage of using systemic or adjuvant treatments immediate post-treatment, at least in the setting of GBM. One thing I will say with timing is I kind of pressure our oncologists in terms of treating them. I usually tell them that they can resume treatments the day after LITT, as long as the patient is stable. So I think we really got to take that opportunity to start systemic treatments as soon as the patient is stable. Typically, we want, at least at our center, I know our neuro-oncologists will start LITT within a week of treatment. So I think that's something which I think will benefit. Clearly, we'll have some data hopefully in the next year or so showing that advantage.
Certainly does seem one of the most active areas of research for LITT in the newer studies that we're seeing. There's some really interesting publications coming out on that end as well.
I was just going to address this question from SRS standpoint. That's an excellent point. I think people have had a fear for using chemotherapy or systemic therapy with SRS, mainly because of the concerned toxicity. Because when you open up the blood-brain barrier, you allow drugs to get in for treatment efficacy, but you're also worried about, will that agent in the brain cause any side effects? So because of the fact that we're able to use SRS, which is very focal, our practice is basically we only hold if it's oral agent, if a patient is on oral agent, which typically is target agent, we only hold the agent for 1 day. So the day of the procedure, or 1 day, maybe the day before, the day after, at the most 3 days. But if the patients forgot to hold the chemo agents, we don't stop treatment. We move forward with treatment. So, and for systemic therapy, like the real chemo, we usually try to give about 3-day interval. So they can have chemotherapy 3 days before, 3 days after. So those are for the conventional chemo. And then for immunotherapy, we don't really put down a limit. So they can have the immunotherapy the day before or the day after. And the only reason we don't do the day off is because of the logistic reasons. We have some preliminary data to show actually if you deliver the 2 treatments closing time, the outcome is better.
I would love to see something like that. And I think that is all a part of the multidisciplinary approach that we need to be able to demonstrate with a technology this amazing and with people as experienced as, yourself, Dr. Prabhu. This is, I think, very much worth adding to the discussion and getting those medical oncologists and neuro-oncologists on board to see that there should be less fear, and less trepidation moving forward with that type of approach.
Yeah, you're exactly right. So I think one of our job is really just to educate our medical oncologist colleagues that they don't have to wait. So we have to do that, I think, oftentimes on patient by patient basis.
So I have a question regarding steroid tapering after LITT. So as we know, the tumor starts to having significant edema after the surgery. So how do you taper the steroids? How long you put the patient? A lot of these patients are steroid dependent. They want to get rid of steroid as soon as possible. So you mentioned that your experience is like 3 months, even like the edema gets worse and gets better. So you put the steroids 2 to 3 months after LITT?
Yeah, that's a good point. I typically choose the use of steroids very sparingly, and it all is dependent on the amount of edema and location, as you know. Though the edema pattern still persists past, say, 6 weeks, 8 weeks, and so on, if the location is such that the patient is asymptomatic, I typically will taper steroids to stop very quickly within a week to 2 weeks. And I've had some outliers where we have had to restart steroids just because of symptomatic relief. But I would say, and we are looking very carefully at our own data, so I would say most of our patients are off steroids within 2 weeks of LITT. And I've also gone that extra step in terms of stopping steroids very quickly after the treatment when I feel that it's a small lesion, it does not really require any steroids. I've stopped it within 2-3 days. So I think there's no, I wish there was an algorithm to show that. I don't think anyone has. It's your best clinical judgment, but you want to be aggressive with tapering steroids.
Yeah, I think many would agree that the steroids really, it has to be a symptomatic, approach, because we know that using steroids in a patient, for example, that's on immuno-oncotherapy is going to negate the effect of the neuro-oncotherapy or immuno-oncotherapy. So I think that it's really important, just as Dr. Prabhu said, to use that very sparingly and on a symptomatic basis. I am interested to know, how often are you guys using prophylactic Keppra and other anti-epileptic drugs prior to surgery? I see that a lot in open craniotomies and even some of the biopsies.
So our practice here is not to use any seizure prophylaxis in patients who have not had a seizure. So that's just been our practice even for craniotomies or any type of surgical intervention. So I would say, large number of patients really are not on anti-epileptics. Clearly, if they have a seizure, they do. So I think, this is borne out from, multiple reviews and studies, as you are aware. So we just have to be mindful that all patients do not need seizure prophylaxis.
Yeah, I agree with that approach.
So I have another question, very quick. So there are sometimes like recurrent GBM, we decide to do LITT. Obviously, the KPS of the patient is not enough to go through surgery. So I had a patient with temporal lesion that like big branches of MCA was in the tumor. So I was always wondering, do you go with the blue line over these big branches of the MCA, or you stop with the branches? Do you have an experience with like vascular, big vasculature in the tumor?
Yes. So again, these are excellent technical points in terms of I think I pay attention to probe placement. I've had more than a few cases of insular glioblastomas and even metastases. I clearly pay attention to the probe placement in terms of the depth, but once we really start the treatment, we have to be really mindful of the spread. And what I've noticed in most cases is the big blood vessels, like the MCA, its immediate branches, will act as a heat sink. So though you have the yellow or the blue line, which is at the margins of the blood vessels, I'm yet to see any immediate consequences of damage to those vessels. In fact, I've had only one case, touch wood, where we had a delayed ischemic event in a patient post-LITT in a recurrent GBM in the insula. So I've treated a number of insular tumors with no significant challenges from that standpoint. What I'm concerned about is, causing a direct injury to the blood vessels by either probe placement or getting a biopsy or so on and so forth, and that sometimes is a challenge. So blood vessels in general, can be your friend during the treatment.
Mm-hmm.
Well, it's 8 o'clock, so I want to be respectful of all of your time. This has been a great discussion. Thanks so much to Dr. Lee and Prabhu, and to all of you for a lively discussion. Have a great day.